Hi, I'm Caroline Treeple. I'm a hand surgeon in Virginia Beach, Virginia, and I'm here to talk to you today about the Patient Protection and Affordable Care Act. First, I'd like to start with a quote from Benjamin Franklin. I believe it's very important and very helpful. He said, "To relieve the misfortunes of our fellow creatures is concurring with the deity. It is godlike, but if we provide encouragement for laziness and supports for folly, may we not be found fighting against the order of God and nature, which perhaps has appointed want and misery as proper punishments for, and cautions against, as well as necessary consequences of, idleness and extravagance? Whenever we attempt to amend the scheme of providence and to interfere with government of the world, we had need be very circumspect, lest we do more harm than good." After beginning with that quote, I'd like to move on to what is the Patient Protection and Affordable Care Act. We will then discuss issues and problems thereof and discuss a solution. And note I said a solution. It is not necessarily the solution, but a solution to the healthcare problems we're facing in our country at this time. I would like to jump to a quote from James Madison in the Federalist Papers. "It will be of little avail to the people that the laws are made by men of their own choice, if the laws be so voluminous that they cannot be read, or so incoherent that they cannot be understood." So what is the Patient Protection and Affordable Care Act? It is 3,256 pages of regulations and taxes. It's the largest expansion of federal bureaucracy in United States history. It adds 159 new commissions, boards, agencies, panels, and committees, creates over 4,000 new healthcare regulations, 150,000 new federal employees, and of course, the individual mandate that states that each citizen must purchase healthcare insurance or face a penalty or tax. Our current healthcare system arrangement is fairly simple. You have your payers and your patients down at the bottom. They feed into the hospitals. We have our allied healthcare professionals. As a hand surgeon, the common example I use are the hand therapists that I use. And then, of course, the physicians. Now, after you create 159 boards, commissions, agencies, and the like, this becomes somewhat more complicated, as you see in this diagram. In the very center, you're the Secretary of Health and Human Services. If you look up into the very upper right-hand corner in the center, you see the IRS. And then you see some other agencies such as IPAB, the Independent Payment Advisory Board, and so on and so forth. It's a very, very complex arrangement in the Patient Protection and Affordable Care Act. The blueprint, of course, many of us know about, is the Massachusetts Healthcare Insurance Reform Law. It was passed in 2006. The short-term implications of the Massachusetts law are concerning. Between the interval of 2003 and 2008, the United States average premium increased 33%. However, in Massachusetts, the average increase in healthcare premiums, 40%. Now, you match this increase in healthcare insurance premiums with wait times. Over the same interval, wait times increased to the longest in the United States when you look at Massachusetts. If you're waiting to see an OBGYN, your wait went from 45 days to 70 days. If you're waiting to see an orthopedic surgeon such as myself, your fracture would probably be healed by the time you get to see me, because your wait would increase from 24 to 40 days. Now, as you can see, as you have an increasing wait time to see specialists, there will be an increasing use of emergency departments, which are the most expensive portal for care. Short-term implications of the Patient Protection and Affordable Care Act. Medicaid is a leading budget item for most states, and under PPACA, there will be 18 to 24 million new enrollees in 2014. And by the end of the decade, it's estimated there will be 84 million new enrollees in Medicaid, and states only receive 2 years of a federal subsidy. What's going to happen after that 2 years? The tax burden will fall from the federal payers to the state payers. Physicians are only reimbursed 60 cents on the dollar for seeing a Medicare patient. So, the way I like to look at this is, a physician has to pay to see a Medicaid patient. If we draw an analogy with a mechanic, let's say you own a car shop. Somebody comes in to have their car fixed, and they need a new transmission, and you tell them that the cost of the transmission is going to be $1,000 plus the cost of labor. Well, the client states they're only going to pay you $600. You might be able to absorb that cost, but if, say, 20% of your clients come in and only offer to pay you 60% of your costs and no labor, it's going to be very difficult to keep your business open. So it is for this reason, with Medicaid, many physicians have to opt out or limit the number of Medicaid patients they see. And this, in turn, also leads to an increasing use of emergency departments for these patients. Now I'm going to cone it down to one state. This is actually the state in which I live at this time, Virginia. At this time, there are 1 million enrollees in Medicaid. And Medicaid is 17.3% of the state's fund. Now, in 2019, by full implementation of Obamacare, there will be an increase in Medicaid enrollees by 41%. And Medicaid will jump from 17.3% of the state's budget to approximately 30%. Again, physicians in Virginia are only reimbursed 60 cents on the dollar for Medicaid patients. And like Massachusetts, this will translate to an increased cost burden on taxpayers and will not guarantee increased access for these patients who need care. Long-term implications of the Patient Protection Affordable Care Act. This is designed to fail. The Secretary of Health and Human Services decides what is covered. The feds regulate the insurance premiums. There are intentionally low penalties or taxes, whatever you want to call it, if you do not participate and purchase health care insurance. A patient can wait until they're sick before they purchase insurance. And there's a guaranteed issue, and there's no caps for the insurance companies. This will make it impossible for insurance companies to stay solvent. As a result, insurance companies will collapse and will evolve into a single-payer national health care system. Massachusetts has already seen the exodus of many insurance companies and currently only has 4 major providers. Let's discuss some further issues and problems with the Patient Protection Affordable Care Act. We've already discussed cost issues. Now we're going to discuss constitutionality. At the end of March, the Supreme Court of the United States heard 4 arguments regarding PPACA. First, if the health care law constitutes a tax, does a court have jurisdiction? We'll go into each one of these issues in the following slides. Second, and this is the one that has attracted the most attention, is the individual mandate to purchase health care insurance constitutional? Third, if the individual mandate is not held to be constitutional, can the rest of the law survive? And last, is the law's expansion of Medicaid an unconstitutional intrusion on the states? And we already saw some discussion of the implications of PPACA on Medicaid in the previous slides. We'll delve a bit further coming up. So the first day, the Supreme Court heard 90 minutes of argument regarding whether the health care law constitutes a tax or not. And this has to do with the Anti-Injunction Act. The Anti-Injunction Act prohibits courts from striking down tax laws before they take effect. The intent of the Anti-Injunction Act was to prevent citizens from suing before paying taxes. So the argument goes here that if the penalty for not obtaining health care insurance is a tax, then the Supreme Court can't hear the rest of the arguments. Second, is the individual mandate constitutional? The Supreme Court heard 2 hours of arguments on this. There was a wonderful debate between the Attorney General of Virginia, Ken Cuccinelli, and the Attorney General from Massachusetts, Martha Coakley, that took place on February the 9th. And it sums up, basically, the Supreme Court arguments pretty well. It all boils down to the Commerce Clause, which is in Article 1, Section 7 of our Constitution. The Commerce Clause is designed to, quote, regulate commerce with foreign nations and among the several states and the Indian tribes. Now, the key is the first 3 words, to regulate commerce. Ken Cuccinelli and the 26 other states that have brought forth arguments to the Supreme Court state that by forcing patients to purchase insurance and forcing citizens to purchase insurance, you are regulating inactivity into activity. And that's in direct violation of the Commerce Clause. Martha Coakley, the Attorney General for Massachusetts, argues that all participate in health insurance, and therefore it could be regulated. So you can see where this is a sticky argument. Third, if the individual mandate is not constitutional, can the rest of the law survive? And the Supreme Court heard 90 minutes of argument regarding this, and this basically boils down to severability. If the individual mandate is struck, can the rest of the law stand, or does the rest of the law fall as well? The fourth argument, which did not obtain much press, but is very important nonetheless, dealt with Medicaid. Is the law's expansion of Medicaid an unconstitutional intrusion on the states? The Supreme Court heard 60 minutes of argument regarding this, and this deals with the coercion theory. Federal Medicaid funding will be taken away from states that do not comply with PPACA. And the states have argued that Congress is therefore working to achieve something that they don't have the power to do, which is to expand Medicaid. Lastly, we're going to consider all of these issues and problems with PPACA together because there's no one way to really extricate each one by one. We're going to discuss how healthcare decisions will be taken away from patients and their physicians. We'll discuss the rationing mechanisms that are inherent to PPACA, and we'll briefly discuss how this infringes on our freedom and liberty, both with regards to whether or not to purchase health insurance and also in choosing our own physician. Now, to discuss these issues, we have to look a little bit at the architects of PPACA. Donald Berwick was a recess nomination to head CMMS. He's a Harvard academic, and he has a professed love affair with the British national healthcare system. He's described it as a seductress about which he is romantic, which is interesting. And another fact that is notable is that the British healthcare service is the 3rd largest employer in the world. Now, the United Kingdom does not have the 3rd largest population in the world. And then the following argument is, does Britain have the 3rd best healthcare in the world? Dr. Berwick believes that healthcare should be rationed and that the healthcare delivery system must redistribute wealth and it must decentralize doctor decision making. That means that algorithms will be created that tell us, physicians, how to take care of you, the patient. Now, if I have a patient who presents to my office with a wrist fracture, I will know best as to what type of hardware would help put that fracture back together, whether simply manipulating the fracture into place would be the best course of treatment. I will know more about that patient's help at home, whether they have help at home after surgery or if they would do better with a cast, if their health isn't so that they could tolerate surgery. An algorithm is not going to help me improve my health care of my patients. And that is the way that it is for most physicians. Dr. Berwick resigned. He realized there was no chance of approval in the Senate, and the first deputy was now nominated, Marilyn Tavenner. She was a former Virginia Secretary of Health and Human Services under Democrat Tim Kaine, and she has already stated that there will be no changes of implementation of Dr. Berwick's policies. We next need to look at the second most powerful person in the United States of America. That is the Secretary of Health and Human Services, Kathleen Sebelius. She is a former executive director of the Kansas Trial Lawyers Association between 1977 and 1986. She was then an insurance commissioner. She will determine, along with her 159 commissions, boards, agencies, and the like, the definition of quality medical care and the standard of American health care. She and her groups will determine minimal essential coverage and will be the sole authority to establish patient treatment and eligibility protocol. She will oversee the implementation and enforcement of PPACA. Let's discuss the rationing mechanisms. There are three. We'll start with the Federal Coordinating Council for Continuing Research. This is the Rationing Board. It was not created in PPACA. It was actually created during the stimulus bill in 2009. It's a 15-member politically appointed board, and it was put into place within 72 hours of passage of the stimulus bill. What this board will do is compute comparative effectiveness ratios, which will take the cost of treatment divided by the number of years of benefit. This is analogous to the British, quote, NICE board and their quality adjusted remaining years. These ratios will determine if you receive treatment. If your comparative effectiveness ratio is favorable, you receive treatment. If not, you will not. Now, to help the rationing board determine and enforce algorithms, we have the National Coordinator for Health Information Technology. This is the enforcer. This will institute the decisions of the previous board that calculates the cost-effectiveness ratios. It will guide medical decisions at the time and place of care. So as your physician is typing in their treatment protocols, it should go through the system all the way to the National Coordinator for Health Information Technology, and they'll determine, yes, that's the right course of action, or no, that's not. And physicians and hospitals who are not meaningful users over time will face penalties. These include exclusion from insurance exchanges and fines. But again, I say to you that almost all physicians know how to take care of their patients better than relying on an algorithm. Third, there's the Independent Payment Advisory Board, or IPAB. This group has gotten a lot of attention in the medical press. It's an unelected, politically appointed board whose purpose is to reduce spending in Medicare. These will determine covered services and fees. This is a further way to ration care. So, looking at the law of supply and demand, there are 25,000 physician graduates per year. And at this time, there are 35,000 physicians that are retiring. Within 10 years, this alone creates a 100,000 physician deficit over 10 years, even without PPACA. Now, Investors Business Daily conducted a study in September 2009, and at that time, 65% of doctors were opposed to PPACA, and 45% of them would consider retiring. So, the 100,000 physician deficit will likely be even greater. So our president adds 32 million patients to Medicaid. And in addition, with the baby boomers beginning to age up, we'll see a 30% increase in Medicare over the next 10 years. PPACA cuts $575 billion from medical care, from Medicare. So you increase the number of enrollees 30%, you cut Medicare $575 billion, and somehow Medicare patients are going to have better care under PPACA. It just doesn't make sense. We'll have a critical shortage of physicians. We'll have the IPAB decisions to further cut spending in medical care, and rationing will be inevitable. Let's look at socialized medicine, because that's essentially what we're moving toward. We're going to look at the UK, and we're going to look at the United States. This is a study that came out in April 2008. Prostate cancer death rate falls 4 times faster in the United States than the UK since routine screening. Now, obviously, that's just one headline. This is a very busy slide just to show that healthcare, health insurance, is not a black and white single issue. The first column, we have the total expenditure on healthcare as a percentage of GDP. And if you look at it, the UK spends the least, and we spend the most. Then you look at the per capita expenditure on health. Again, the UK spends the least, and the United States spends the most. Now, I want to harken back to one of my earlier slides. The British healthcare system is the 3rd largest employer in the world. Where are they spending that money? It's not on medical care, as you can see. They're spending it on administration. Now, we're going to look over at the mortality rates. The life expectancy amongst the 3 countries are very similar. You look at the mortality rates due to cancer, and you see the United States is considerably lower than the UK. Canada, overall, fairly similar. You look at deaths due to heart disease, and you see the United States leading the way. Canada is doing the best. You look at obesity. You see that Canada and the UK both have obesity rates of approximately 22%. We're a full 10% higher. This is where things are not so simple. Looking at mortality rate for certain cancer diagnoses, the UK versus the United States. The UK has 88% higher mortality rate in breast cancer and 604% increased mortality rate for prostate. I can't even wrap my head around that number. If you look at Canada versus the United States, breast cancer mortality is only 9% higher. Prostate cancer, I don't know how I could say this, only 184% higher. So, looking at other factors of socialized medicine versus United States healthcare currently. Innovation. The top 5 hospitals in the United States conduct more clinical research than any other country in the world. Now you see, with creating 159 new boards and agencies, there's going to be a lot of money that's not going towards clinical research. Since the mid-1970s, the Nobel Prize in Medicine and Physiology has been awarded to more Americans than recipients from all other countries combined. We have wonderful innovation in the United States. Now, let's look at why PPACA was created. PPACA was to take care of the uninsured. Who are these uninsured anyway? We all want to take care of them. There are 47 million uninsured people in the United States. And if you look at this pie chart, there's basically an upper half and a lower half. We're first going to look at the lower half. You can see that there are 9 million in the green piece of the pie, 9 million Americans that earn more than $75,000 per year and choose not to purchase health insurance. You look at the purple piece of the pie. There are 9.7 million that are eligible for government programs and choose not to participate. We'll move one piece over to the left, and you see that there are 6 million Americans that are eligible for employer-sponsored insurance and choose not to. So that 47 million uninsured, divide it in half, because half of those are eligible and choose not to. You're down to 23 million. Looking at the top half of the pie, out of that 23 million, 12 million are Americans without affordable options. You then have 5 million legal immigrants and approximately 5 million illegal immigrants who are uninsured. So whether you look at 12 million uninsured Americans or 23 million uninsured people in the United States, we need to look at this number. 85% of Americans in a recent study were satisfied with their current insurance. And here's an interesting fact. The CMS, in an analysis published April of 2010, stated that by 2019, after full implementation of the Patient Protection and Affordable Care Act, 23 million Americans will still remain uninsured. What has it fixed? We've added an unfathomable level of bureaucracy and cost, and we haven't changed the level of insured at all. American healthcare is the envy of the world. PPACA breaks two promises for reform. It fails to achieve universal coverage, and it fails to bend the cost curve down. Now we're going to talk about a solution. Again, not necessarily the solution. There are lots of wonderful ideas out there. But we're going to talk about a solution. There's an organization called Docs for Patient Care, and we are a grassroots organization of physicians who are very, very concerned about what's happening to the sanctity of the traditional doctor-patient relationship. Docs for Patient Care was formed in May of 2009 to inform the public of the unintended consequences of PPACA. And we also want to put forth alternative proposals that preserve the autonomy of physicians and patients. We believe that doctors and patients are most capable of making the best and most informed personal and accurate decisions, not a federal, state, government, or any third party. Now, there are 3 R's of sustainable reform. There's medical liability reform, there's insurance reform, and there's personal responsibility. First, we'll talk briefly about medical liability reform. The United States has 5% of the world's population, but 94% of the world's lawsuits. I just have to repeat that again because it's really an intriguing and fascinating number. The United States has 5% of the world's population, but 94% of the world's lawsuits. I want to give you some examples, or one example, of an unintended consequence of the number of these lawsuits. There is an OBGYN practice in the country, and they went for their monthly meeting where they discuss front office staff, billing procedures, and the like. And they found out last month that their medical malpractice carrier was planning to drop them. So your first thought is, well, those doctors must not know how to practice medicine if their medical malpractice carrier is going to drop them. Yet this practice had not lost a single lawsuit that had been brought against them. The reason that their medical malpractice insurance was going to drop them was because of the sheer number of lawsuits that had been brought up against this particular practice by one law firm. The cost of defending this practice is not worth it to this medical malpractice carrier. As a result, this practice may have to exit the county, leaving a very large county in South Carolina without obstetrical care. This is wrong. There are costs to defensive medicine. There was a study that was published in the American Academy of Orthopedic Surgeons, and it stated that 90% of doctors perform defensive medicine, and that is absolutely true. 92.5% of orthopedists alone ordered imaging studies defensively in order to prove that there was nothing wrong or prove that something was wrong. Physicians attribute 34% of overall healthcare costs to defensive medicine. It is extremely hard to really measure this, but physicians freely estimate a third of our costs due to defensive medicine. Liability reform is estimated to cut healthcare costs anywhere between 5 and 34% by reducing defensive medicine. And almost half of doctors have restricted their practice for risky procedures or patients with complex conditions or potentially litigious patients. Let's talk a little bit more about medical liability or tort reform. It has been estimated that defensive medicine adds $1,700 a year to a family policy. We need better solutions to medical liability than our current system. We should have medical specialty courts that determine the merit, and monetary judgments are calculated by an expert panel. We need caps on non-economic damages or a loser pays system. The loser pays system is where the losing attorney inside pays the other side's costs. This would cut down on frivolous lawsuits considerably. Medical specialty societies need to decide best practice guidelines, not bureaucrats. The second R of sustainable reform is insurance reform. Health insurance was not tied to employment until World War II. At that time, there was a certain labor market that was available, and it was very limited because of the war. There were caps that were placed on what these workers could be paid. So as an additional incentive, health insurance began to be offered as something extra that they could get these good workers with. Health insurance currently is not sold in a true free market like auto insurance across state lines. It's heavily regulated by states and burdened by legislative mandates, and these expensive options that must be included in a policy only drive up costs further. There's a lack of competition, there's a presence of mandates, and the costs are not transparent. The costs should be transparent. Doctors share some blame in this as well. If a patient walks into my office and has a ganglion or a mass that needs to be removed and asks me the cost, I should be able to say it costs X amount of money. Instead of saying, well, let me write down the CPT code and you can go talk to your insurance company and find out. The costs need to be transparent. True insurance is similar to auto insurance. Your auto insurance doesn't pay for your wiper blades. It doesn't pay for your gas. It covers for catastrophic loss. True healthcare insurance should cover the risk of catastrophic loss that most could not afford. An example of a type of insurance which encourages this are health savings accounts. And these put the policyholder, or you, or me as a patient as well, in control of the money and helps us make the decisions that are best. And true insurance should be portable. We should be able to take it with us when we change jobs. This is not supported in PPACA. True insurance reform would eliminate interstate restrictions to the sale of health insurance. It would give the same tax breaks to individuals as we give to employers, create high-risk pools for pre-existing illnesses, and allow small businesses and individuals also to pool their risk. We need to separate or divorce insurance from employment. So if you purchase an insurance policy at age 20 that works for you, it is appropriate for you, if you change jobs, your insurance goes with you. And we need to encourage the use of health savings accounts. In health savings accounts, individuals allocate a portion of their earnings in a tax-free investment account. Patients use this money to pay smaller medical expenses, leaving high-deductible, low-premium insurance to cover the high-cost catastrophic medical events. So if I have a patient that comes to my office and they have a mass, and we discuss whether or not a study such as an MRI should be ordered, that patient would be able to get the MRI at the facility that costs the least. It would help drive down costs. These would bring direct incentives such as these to consumers or patients to help control costs and stimulate true market cost control competition. This empowers each patient to make the most cost-effective and best decision for their own health care. If you don't use the money, you keep it. HSAs have been shown to reduce health care costs. There was a study in Mackinac Center for Public Policy which estimated that $200 billion a year would be saved with HSAs. And there's an increased use of preventive care by 20%, as evidenced by a study of the Indiana state employees that was published in the Wall Street Journal in March of 2010. Let's discuss the third R of sustainable reform, personal responsibility. I'm going to return to the slide that I showed earlier, which showed the total expenditures, the percent GDP, so on and so forth, life expectancy, cancer mortality rates, and as you see in the lower right-hand corner, obesity. We need to take more personal responsibility for our own health. The United States leads the world in rates of obesity, tobacco, and alcohol use. It is estimated that obesity-related diseases cost $180 billion a year. Tobacco-related illnesses, $75 billion a year, and is estimated to take up 14% of the state's Medicaid budget. And preventable injury costs around $150 billion a year. Determinants of an individual's health and early death, 40% are due to lifestyle and behavior. That's where personal responsibility comes in, 40%. 30% is your genetic makeup. Nothing can change that. Your personal responsibility sometimes can influence it. Your health insurance won't. 20% is social, environmental, and only 10% of early deaths are attributable to a lack of access to medical care or the healthcare system. So as PPACA, we're going to look at promises on the left versus reality in yellow on the right. Our president stated that the average family premium would go down $2,500. More recent estimates show that the CBO estimates that it's going to increase $2,100. That's a difference of almost $5,000 for each family per year. There's a lot that each family could do with $5,000. Initially, the cost of PPACA was estimated to be $938 billion, but more recent estimates have shown $1.7 trillion. Huge. And this is not going to improve health care. In March of 2010, it was estimated that the debt over time would decrease $138 billion due to PPACA. 2 months later, just 2 months later, the former CBO director said, no, it's not going to decrease the debt by $138 billion. It's actually going to increase the debt $554 billion the first 10 years, and then $1.4 trillion. So again, we are spending a lot of money, and it's very likely that patients will have decreased access, decreased choice, decreased quality of health care, and increased wait time, all for this huge cost. Now, the new health care law affects two groups of Americans, patients and physicians. I guess that makes me two people since I am a patient and a physician. We need to work together to get health insurance reform right. Our current system isn't working. PPACA is not going to work. There are really great options out there. Get involved. Join Docs for Patient Care. Facebook us, like us, follow us, learn. There's printable information that you can download for your physicians. Tell your doctors about us. Direct them to our website. Make a donation to whomever you would like. Docs for Patient Care, your local Tea Party, a candidate of your choice, local Republican Party, etc., etc. And in the lines of our great leader, become a community organizer. Or write editorials, run for precinct manager, city council, get involved. Educate yourself, educate your neighbors, educate your fellow workers, and most importantly, vote.